Good morning. So we're going to start with a patient who is a 56-year-old man. He has the usual vascular comorbidities, although he is young and highly functional: hypertension, hyperlipidemia, CAD. And he had actually had a rather extensive prior history of aneurysm repairs. He initially presented about 5 years prior with a infrarenal AAA, and then actually degenerated and got a large type 1 leak as his proximal neck dilated. And that was actually treated in a prior session with a proximal extension. There was not enough room to just put a standard cuff in order to extend proximally, and so actually a fenestrated cuff was used in order to proximally extend. I say a fenestrated cuff, but it was really just the fenestrated component without the bifurcated component. There was enough room before the flow divider in this patient. He now is presenting actually with bilateral hypogastric aneurysms, and that's really what we're talking about today. On physical exam, he had a rather sizable midline mass. However, it was not pulsatile, which was a nice finding given that the aneurysm appeared not to be pressurized anymore. This is a slice of his axial CT, really at the level of the flow divider. You'll see the fenestrated component in the angiograms that follow. And as we go down, we see that nicely excluded large AAA. Here you can see the right limb appears to be an ectatic or aneurysmal common iliac. And then really at the bifurcation, there are these two hypogastric aneurysms. These vessels are actually quite large. Those were around 4 centimeters. 4 centimeters on the right, 3.7 on the left. So we have a patient with bilateral hypogastric aneurysms that are untreated at this point. They're certainly large enough to warrant repair. And the traditional method of treating this would be essentially staging a coil embolization of both hypogastric aneurysms and then extending into the external iliac artery in order to get a good seal across those hypogastric aneurysms. There are drawbacks to that traditional approach, though. The most obvious one is that this patient would very likely end up with some amount of buttock claudication with both hypogastric arteries occluded. The patient is young and highly functional, and that's a non-ideal outcome. The other issue is that he does have already reduced blood flow to his gut in the sense that his IMA was covered on his previous interventions. And so preserving those hypogastric arteries really reduces the chance of any colonic ischemia. And finally, spinal cord perfusion is certainly something you think about, especially in a patient who's young and has already shown that he tends to degenerate further. If this patient needed more extensive coverage later, either in his thoracic aorta or elsewhere, that could cause problems for spinal cord perfusion. So now there's the Gore branch device, which allows us to actually preserve hypogastric arteries. And it was really a device designed to treat common iliac aneurysms. And it has a side branch, which then allows you to keep that hypogastric open. We used it a little differently and actually extended into the more distal hypogastric artery in order to seal a primarily hypogastric artery aneurysm. And so that's actually what we elected to do, is go ahead and treat with an IBE on the right, and on the left, go ahead and treat with a standard repair. Here is our diagnostic angiogram, although this was done at the time of the repair. You can see the nice proximal seal with those fenestrations there. There's a stent in the SMA, both renals. I think that's a large fenestration for the SMA there. You can see the crossed configuration of the endograft. I think that was the initial graft as an endurant. And then you see that ectasia in the common iliac on the right, and then the hypogastric artery aneurysm on both sides is apparent there as well. So the first part of the procedure is really that standard procedure that we discussed, coil embolization of left hypogastric, and then distal extension with a extension piece. That was done really in a standard fashion. You can see a nice tight coil pack there with late filling of the branches of the hypogastric distally there, which was all really done fairly easily. We then extended and sealed into the external iliac artery. I think we actually ballooned after this picture a little bit. You can see there's a little trace of contrast there, but we ensured there was no type 1B. So for those of you not familiar with the IBE device, the next part of this could be a little bit confusing. So I wanted to run through quickly what the GORE IBE deployment's like. Essentially, the first thing you do is you end up snaring a wire up and over in order to have access a kind of flossed wire from the right, from both sides. You then have a through wire, which is essentially positioned up in the thoracic aorta like you would usually do for a standard EVAR deployment. And what you actually do is you load the device on the through wire as usual, but then you backload the through wire, the one that's flossed, through a channel that actually is already through and through that branch component. And that allows you can see right here, that's the branch component, and the through and through wire is backloaded through it. So this pre-cannulation technique is really how GORE is going forward with the majority of their branch technology. The TAMB trial utilizes this as well. And so once the device is advanced into the patient, you are again pre-cannulated. You then thread a sheath up and over along that pre-cannulated wire. And so now you're inside the branch, and through that stable system, now that you have that sheath up and over, you can then cannulate the hypogastric artery and extend with the extension pieces and get a nice seal in the hypogastric artery. Of note, I like that they actually show that this through wire, you can see the sheath is being advanced over the through wire, and the wire is still through that branch and actually still coming out the patient over here. Most people then lose access with that through wire in order to start cannulating the hypogastric artery and doing the manipulation there. In this case, we actually maintain that through wire because we wanted the ability to really snug down our up and over sheath. The reason being is that we weren't working on a normal bifurcation. Remember, we already had a device in place, so we're working on this flow divider, which is sitting up in the more proximal aorta, creating a really kind of nasty angle for us to work over. But by maintaining that through wire, we're able to tug down and give us enough of a favorable angle to still do the procedure. This is actually after we've already snared the wire, pulled it through, we've cannulated the branch gate, and we've advanced a catheter through the branch and are performing an angiogram. You'll see our setup with that sheath up and over in a few moments, but I wanted to give you a nice picture of what that hypogastric artery aneurysm looked like, and that seal zone, which is right here. It's a little bit tortuous, that when we opened it up with another oblique, you could really see that there was a good 2 centimeters of seal segment for us to land in distally. We used the standard extension piece, which I think is 13 by 100, and then we extended a little further with a Viabon, which is 10 by 70. You'll see that these things tracked beautifully up and over our sheath. And here is, we've actually already deployed the proximal extension piece, and then this is the distal Viabon being positioned into that hypogastric. You can see it's nicely constrained distally in the seal area, and again, there was at least approximately 2 centimeters of stent in there. This is our sheath. You can see it's up and over this flow divider way up there. And you look at that and you think, how did we track stents over it? And it actually was fairly easy. The sheath we used was quite flexible and supported. I believe we use an Ansel for this, actually. And by maintaining that through wire, we're really able to snug down and make that angle as favorable as possible. But this has been described before, an IBE the device being used after a prior endograft repair, but usually the operators have chosen to come in from above and floss that way and backload onto the device and then work from above, from the axillary artery usually, or you could go brachial if you have the right lengths. We chose to just try to do it up and over and just spare the patient that additional access point. And honestly, it wasn't that hard. We were able to do it quite easily. Now we have some nice completion shots. You can see that left side is nicely sealed where we extended and embolized. And then on the right, you see that nice filling of the hypogastric, those two branches, anterior, posterior, and really exclusion of that large aneurysm there. The only thread of contrast you see in between, I think, is the ureter. And there you have it, completely excluded. As far as we know, we looked through the literature, there's certainly no published reports of using an IBE after a previous fenestrated repair. There has certainly been IBE reports done after prior endograft repairs, and like I mentioned, they were usually done from above. So we thought this was a relatively novel technique, certainly the first time we did it here. And the big technical pearl we took away from it was keeping that flossed wire in order to really allow us to get the sheath into a favorable position. And if anyone had any questions or comments, love to hear them.